everybody. Thank you for being here. My name is Maria Santi. I'm a health insurance partner at Your Insurance Attorney. I am also the chair of the Health Law Section's Diversity and Inclusion Committee. Today's fireside chat will focus on 3 areas related to COVID-19 and prevalent disparities. We'll focus on vaccines, treatment, and testing. And as many of you may have seen, I'm sorry, before I get started, please be sure to mute your microphone. And then also, if you have any questions, please hold them till the end. You could also put them in the chat. We will have a question and answer session at the end after all the speakers have presented. So just housekeeping matters. Thank you. All right, so as many of us know, many articles and research over the last few months have determined that there are many disparities in the wake of COVID-19. The CDC has stated that longstanding systemic health and social inequities have put many people from racial and minority groups at increased risk of getting sick and dying from COVID-19. The COVID Tracking Project, which is a nonprofit volunteer group, has also found that Black populations, Indigenous populations, and Latin populations, and other people of color are being affected in worse ways. And there are disparities there. If you want to look at that project, you can go to COVID Tracking, www.covidtracking.com. And lately, the Kaiser Health Foundation has also found that certain Black populations are not getting vaccines as fast as other populations. So there are definitely disparities in the wake of COVID-19. And today we have a distinguished panel of speakers that will discuss the issues. We have Dr. Carisa Champion, Dr. Joshua Lenchus, and Dr. Leon Haley. They're going to share their experiences at their hospitals and any issues related to their involvement in the community and health initiatives, and any laws and policies that may influence programs in the community or government-related initiatives that have led to disparities. So to begin, I will introduce Dr. Carisa Champion. She is a general surgery resident at UF Health in Jacksonville. She is the first physician to go to medical school and law school at the same time, while also simultaneously pursuing a master's in public health. She has served as a White House intern and worked with the Department of Health and Human Services on health-related initiatives. She has served on many national boards, such as the American Osteopathic Association, the Academic Consortium on Criminal Justice Health, and the DO-Care Medical Mission Board. She is the past national board chair of the Council of Osteopathic Student Government Presidents, national director of Omega Beta Iota, National Osteopathic Political Action Honor Society, and was a co-founder of multiple mental health awareness task forces. Additionally, she is a former training in policy studies fellow and has been involved in health policy information in topics such as e-cigarette regulation, sustainable growth, and other national and state health issues. Currently, Dr. Champion is the president of the Health First Coalition, an advocacy group to empower patients in collaboration with doctors, lawyers, and lobbyists. She's also an adjunct professor teaching professional ethics and health law to public health and medical students. She just finished her surgical communications fellowship with Grey's Anatomy, where Dr. Champion has highlighted COVID testing and treatment disparities for the current TV show's season. So if you haven't seen that, she's behind it all. Also, she is the lead of patient education for patient access care, where she worked on the front lines of testing Eli Lilly's new FDA-approved monoclonal antibody to treat COVID-19. And she's very passionate about the intersection of medicine, law, and policy, and continues to advocate for patients locally and nationally. And on a personal note, something that you may want to know about her, Dr. Champion has a relative obsession with Star Wars. So you may see that among her online profiles. So with no further ado, Dr. Champion.
Thanks, Maria. So hi, everybody. Thank you for having me. My name is Carissa, and I am a physician at University of Florida Health in Jacksonville. I think the reason I was asked to be a part of this discussion was my experience mostly in research dealing with health disparities. So over the past 7 months now, I guess, I've been working for Care Access Research, which is a research company that partners with sponsors like Eli Lilly, AstraZeneca, et cetera. And we've been working on multiple sponsors on developing treatments for COVID. In November, our first one was FDA approved, bamlanivimab, which is a monoclonal antibody that treats and prevents COVID depending on what studies you look at. And so I think one of the interesting things is what I've learned through that experience was the way that we did research was a little different. Usually when you do research, medical research, you have patients that go to a clinic or a hospital or a lab, and the patients come there to get this research, to get some type of an experimental treatment. And that's how we make progress in finding different treatments for different illnesses. With COVID, there's been a lot of discussion about, there's these different vaccines, there's these different treatments out there, how long have they really been tested? And those are all, they're all valid questions, but within the sector of research, specifically for COVID, the way that we did our research was we actually went to patients. So I think it's 43% of the United States deaths from COVID-19 have been related to some type of a facility, some type of nursing home or assisted living facility. And so what we did for our first approved, FDA-approved medicine was we actually went to these facilities. Once they had an index case of COVID-19 that was positive, we would travel all over the country, every state almost, and bring with us a mobile lab. And we would actually set up a lab in these facilities for 7 days and infuse these monoclonal antibodies into anyone who was interested that lived or worked in these facilities. So something that really struck me when we first started doing this was we would go into these facilities, and some of the residents were really scared of us. And, not that I blame them. We're coming in and we're saying, hey, we're having an experimental medicine and we want to offer it. But it was kind of a stark difference. There were some people that were eager to get it, and there were some that were really afraid of the idea of research. And what we noticed was that the majority of those that were afraid were mostly African Americans or those from a low socioeconomic background. Now, that's not surprising given a lot of the history behind research in the United States, unfortunately. Like she said, I teach ethics. So for those of you who are familiar with things like the Tuskegee experiments, there's definitely a history in the United States that can justify some of that fear among these populations. However, the problem is that a lot of these diseases, and COVID is one of them, can have a much more concentrated effect in these populations. So things like asthma, prostate cancer, COVID-19. And we need to be able to find treatments that specifically are able to help treat people. And that includes African Americans, that includes everyone. Traditionally, research has only been done in white males. It's only recently, in the last 50 years, that research started to really open up to the broader population. So some of the concerns is that when we do research, we want to make sure that the drugs that we're developing are applicable not just to white males, but that they're actually going to treat everyone. So in comes that problem, right? So we want to offer medications that will treat everybody. But to do that, we have to be able to use the experimental medications on everybody, people from all different population backgrounds, to be able to say this medicine will not only treat this specific population, but it's going to be applicable to everyone. So I think that was something that really struck me was the fear in those specific populations. So then what we tried to diversify our staff to see if maybe that would be more helpful, if the education about what we were doing would be more easily delivered. And that seemed to help somewhat. But ultimately what we found is that throughout our research, we were able to offer it to people from all different backgrounds, but it was definitely a significant difference as far as the racial backgrounds and who we were able to offer it to, because there was a lot of fear involved. So when you start with the treatments and development, so when we're researching them, when we're developing them, those disparities just trickle out, right? So we're developing medicines that may or may not be as helpful in certain populations as others because we weren't able to test them as much on these populations. So I think today we're going to be talking more about testing and treatment as well as it's rolled out, but you have to keep that context of the background in mind, that it starts with who is willing and who, traditionally has been more open to seeking out experimental treatment. COVID-19 is unprecedented, right? So we had a lot of people that were eager to get treatments, but it's still an issue. We're still developing medications and treatments, and we're still finding this significant fear and significant lack of the ability to be able to broadly say that this is able to treat everyone the same way. And then, like Maria mentioned, I was working on Grey's Anatomy this season, and so something that we really highlighted that I think is important because, patients, the way I see it, patients don't read the studies that we publish. As much as I love research, they go online, right? They go on Google, they go on WebMD, they watch Grey's Anatomy. So for me, that was really important to be able to get some of these messages out. So this season of Grey's Anatomy, and I'm not promoting the show, but my point is that if this is where people are getting their medical education from, that it's important that medical professionals are involved in that. So this season is all about COVID, and something that we do highlight in the season is the disparities that exist in treating and testing, and ultimately in the way that certain populations have been more susceptible to COVID-19 than others have been. So I'm happy to take questions at the end, but that's where most of my background comes from. And of course, I've been in the hospital throughout the pandemic as well. So thank you again for having me on and for talking about this topic.
Thank you, Dr. Champion. We really appreciate that. And I do have one question, if you could maybe clarify for everyone, would you say that the lack of research that you're seeing from specific populations contributes to disparities that we're seeing?
I think yes and no. And I'm sure Dr. Lenchus and Dr. Haley will get into this, but it's not necessarily as much causal as it is associated, right? So people that are more leery of experimental treatments may or may not be similar populations that are more leery of treatment in general, right? So do they trust the treatments once they're FDA approved or not? That may or may not be associated. I don't know that it's necessarily a causation. But if certain populations are more leery of being involved in the upfront process of testing the drugs, are they going to also be the populations that are less likely to seek out that treatment because of their fear? Especially with COVID-19, right? There's a lot of people that are afraid of the timeline and what, is it a governmental, is it a political issue that might also lend itself to some of the distrust? When I was talking to a lot of patients, when I was doing a lot of this research, a lot of them were convinced that I was working for the government and that I was going to inject them with COVID. And I heard that every day. So it was definitely a significant thing across the country. It wasn't even just like certain areas. But yeah, I think that it's more the mindset of certain people when it comes to these types of treatments.
All right, thank you for that clarification. And again, if anyone has any questions for Dr. Champion, you can put them in the chat and we will address them at the end of this presentation. So next we have Dr. Joshua Lenchus. Thank you, Dr. Lenchus, for your time here today. Dr. Lenchus has been named the Chief Medical Officer of Broward Health Medical Center. He will work with medical staff to provide patients with the highest quality of care and will also act as medical liaison between physicians and Broward Health leadership and administration. Dr. Lenchus is board certified in internal medicine and has physician leadership experience, serving for 6 years as chief of staff at Jackson Memorial Hospital. He previously served at Miami Veterans Affairs Medical Center, University of Miami Hospital, and Jackson Memorial Hospital as an internal medicine physician. He was also a former associate program director for the UM Jackson Internal Medicine Residency Program. He has significant experience as a physician and as a medical executive. He has authored several medical publications and books and served as the principal investigator on many research studies. He earned a Bachelor of Science in Pharmacy from the University of Florida and a Doctor of Osteopathic Medicine from Nova Southeastern University. And without further ado, Dr. Lenchus.
Thank you very much for having me this afternoon. I'm going to take a little bit of a more provocative approach here. I agree with what Dr. Champion said. I think that there's a lot of mistrust, but I don't know that that's unique to a particular demographic of people. I think anybody that watches Oprah for their medical knowledge or listens to Jenny McCarthy to give them vaccine advice, no matter what color or what your socioeconomic class is, they're not going to get the correct medical information. And certainly we've done a Herculean job at trying to overcome misinformation over the last 10 months. But the message that I want to convey is that I'm not entirely sure that there is this racial disparity that some people would have us believe. I have read the articles. I know what the data shows. There's a number of reasons why someone gets a vaccine or somebody is enrolled in a clinical trial or not. In fact, in Dr. Champion's bamlanivimab trial for Eli Lilly, 21% of the enrolled study participants were Black, 24% were Hispanic, 47% of them were white, and only 56% of them were male. And when you look at the studies of the drugs that have been granted emergency use authorization by the FDA, you see that the variety, really, if we just want to focus on Blacks as a patient population, spans between 5 and 20%. Hispanics, somewhere between 4 and 40%. So it really is, I don't know that there's a particular reason why somebody is enrolled in a particular trial versus not. I don't know that I would call that a disparity. If there's some element of personal choice in whether you get involved in research or not, that certainly is born out of a number of things like Dr. Champion said. Maybe 70 years ago when the unethical Tuskegee study was conducted, maybe that has dissuaded an entire next generation of folks from participating in research. Unfortunately, that's the nature of the beast, and I think that we have a job in medicine to try to convince people who want to be involved that it is safe and effective, and things that occurred in Nazi Germany in the 1930s are not the way that we conduct experiments anymore in the United States. But when you look at the disparities, I do take odds with some of the data, and the data in the state of Florida show that only 55% of the entire positive COVID population is white. 13% of the COVID cases in the state of Florida occur in Blacks. That's regardless of whether they're Hispanic or not. And so when you look and you translate that, whites have a higher incidence of hospitalizations, whites have a higher incidence of deaths. Now, some would argue that Blacks don't seek medical care. Well, if that's the case, then they would certainly show up in the hospital when they decompensated, or if they died from COVID-19. Obviously, it would be difficult to persuade somebody that somehow your race has to do with whether you suffered from COVID or not. But assuming the opposite, assuming that this data that's being reported to the Department of Health is somehow wrong, and that Blacks are suffering a disproportionate share of cases of COVID-19, that would preclude them from getting the vaccine. So you can't have your cake and eat it too. When you get infected with COVID-19, we know that for at least 90 days, you're protected with antibodies that would prevent you from being reinfected within that time frame. So I would not expect to see that patient population show up for a vaccine, even if they wanted one. And when we look at the governor's executive order as of December 23rd of 2020, the executive order makes no mention of race or socioeconomic class, makes no mention of whether you're Hispanic or not. So it says if you're 65 and over. If you're 65 and over, you can be white, black, brown, yellow, green, orange, blue. Doesn't matter what color you are, you're entitled to get the vaccine, and you don't have to pay a cost because the federal government has already paid for 100 million doses of the Pfizer vaccine and another 200 million doses of Moderna. So I'm not entirely sure. When we look at the COVID vaccine summary, we do see that a predominance of patients that have received the vaccine to date, 64% in fact, have been white, 5% have been black. Maybe part of that reason is like what Dr. Champion has alluded to before. It could be some of that born out of the mistrust of medical research. It could be born out of misinformation that somehow we're going to vaccinate you and we're going to implant a chip that's going to locate you by GPS. And we suddenly somehow we forget the fact that your phone already does that we don't need a vaccine, some global conspiracy to do that. It doesn't affect one's DNA. It's impossible to get COVID-19 from the vaccine. There's a whole host of things that are out there on the internet about people who claim to be physicians that know what they're talking about and in fact misinform the public to a much greater degree than whatever we do to try to combat it. And of course, news cycle being what it is, negative news is always better than positive news. So if I tell you that you're going to get the vaccine and somehow grow a tail, that's going to make national news more so than me saying that that's not chemically possible for that to occur. But then the whole other issue is really why do people wait to get the vaccine? You know, the vaccine's been out. It is under emergency use authorization. That means, you know, I don't have to explain this to a group of lawyers, but that means that you can't mandate the vaccine. You can't mandate something that is still experimental. Now, if later this year, Pfizer or Moderna decide to apply for full FDA approval, like the flu vaccine, then employers could, in fact, mandate the vaccine and with accommodation and religious excuses and medical exceptions, et cetera, but employers can do that. Presently, they can't do that because it is still under emergency use authorization, which means that it is experimental and no one can mandate an experimental drug, which is what the vaccine is. That's not to say that there's not sound science behind what we're doing. In fact, I got the vaccine myself and it didn't make me any smarter or dumber. So it hasn't had any effect on me personally yet. But the question really begs, why do people wait to get the vaccine? And some of it could be the misinformation that's out there. Some of it could be the fact that these people have already been COVID positive recently. Some could be that they have allergies or anaphylaxis to some ingredient within the vaccine that would cause them not to get the vaccine. And then some folks, no matter what we do, some people are just simply not going to take the vaccine because they don't want to take the vaccine. You know, we look at flu as an example. So the flu vaccine, you look at the CDC data from the 2019-2020 season. So for everybody 6 months and older, overall, 52% of those eligible to receive the flu vaccine got it. Of that, 46% were Black, not Hispanic. 55% were white, not Hispanic. So there's no like global conspiracy that 100% of whites are somehow getting vaccinated to the dismay of other patient populations. In my institution, I've set up and run 2 different vaccines of the 3 sites that we've conducted here at Broward Health. And there is no discrimination as to what your color is or what your socioeconomic class is. Our guardrails are what the Florida governor put in place. And that is if you're a healthcare professional with direct patient contact, no matter what color you are, or if you are age 65 or over, no matter what color you are. And I've been at all of our vaccine sites since December 14th when it was received its FDA emergency use authorization, and I have seen people of all walks of life coming there. So I'm not sure like where this is coming from. I'm not sure what the ulterior motive is in promoting this line. There's certainly it would not be lawful or ethical to prioritize a racial minority over another race. That would be sort of reverse discrimination, right? And we know that in our efforts to vaccinate people, the objective is to get the needle in the arms of people that qualify. And there's a rationale as to why they qualify. We give it to people that are 65 years of age or over, because in the state of Florida, that represents more than 4 out of 5 deaths in the state of Florida. It doesn't matter what color you are. If you're age 65 or over and you get COVID-19, you have an 80% chance of dying. So that's why that patient population was selected. Healthcare workers, our patient population was selected, quite frankly, because while private practitioner practices can close, a hospital never closes. And if I wipe out healthcare personnel within the hospital, that will grind our healthcare system to a halt in this country. And that's why those people were vaccinated first. Now, certainly as we roll out the vaccine, I can't hold on to vaccine. So if the people that work in my hospital, if they don't want the vaccine, I'm not earmarking that vaccine for them. I need to open that up and enlist other people who fall into those categories to get the vaccine from whatever walk of life they come from, as long as they satisfy the governor's criteria for now. So I'm very, very curious to hear what Dr. Haley has to say and hear some of the questions that this topic will undoubtedly generate. Thank you very much for the invitation this afternoon.
Thank you, Dr. Lenchus. I did want to ask if, so what do you think may be contributing then to this, the difference in the data out there that is saying that there are disparities between races and populations?
I'm just looking at the data, and I don't see that there's the disparity is what? That somehow that blacks or other minority populations are being underreported for having COVID-19. If that's not borne out by the Florida Department of Health data, they're in there. I don't know. Maybe if they don't seek medical care, they obviously wouldn't be in that data, I suppose. And perhaps that's born out of the fact that there's a mistrust of the medical system in the country. I don't know. I know doctors of every minority that practice who certainly can care for their own patient population if that's the will of that patient population. If a black patient doesn't want to come see me because I'm a white guy, I would say see whoever you need to see, but don't rob yourself of the opportunity to get the medical care that you need. And I would never turn away anybody that meets the guidelines, nor would any health system that I know turn away anybody that meets the guidelines based on the color of your skin. That's absurd. That's offensive. As a physician, that would be offensive. And that person should lose their license and not practice medicine ever again. I wouldn't expect a lawyer to turn away somebody based on the color of their skin. No profession should do that. The fact that that may be happening is certainly not happening at my hospital.
Thank you. And are there any initiatives that Broward Health has now to inform the community about the availability of vaccines and treatments, and you know, just to emphasize that it's available for everyone that qualifies under the order, as you stated?
Yes, absolutely. So Broward Health has taken campaigns, has done promotional campaigns here inside the hospital where we have all walks of life and all colors and creeds. We've made a promotional video and have gone to individual departments to try to drum up support and dispel the urban myths that are out there. There's also community facing. We have a community site where we vaccinate. Broward Health personnel are vaccinated here in the hospital, but we have a community site where we vaccinate the community. And there have been initiatives that are going into different communities to try to drum up support for the vaccine for those who want it. You know, we can't force it on anybody, of course. And as well as holding town hall meetings with different communities, enlisting the help of some of the clergy in the area so that they can promulgate that to their congregations, town leaders, commission leaders, through our physicians that work in the community. So yes, we are making an effort in attempts to try to vaccinate as many people as we can, but this is bounded by the fact that I can't hold on to the vaccine. So, you know, if you want it, come get it. If you don't want it, no problem. I don't, eventually there may be vaccine for you, but there's no way that I could earmark vaccine. That would be completely unethical.
Right, thank you, Dr. Lenchus. All right, so now next we have Dr. Leon Haley. Thank you, Dr. Haley, for your time today. The Health Law section is very appreciative. So I would like to introduce Dr. Haley. He is a board-certified emergency room physician. He is the CEO of UF Health Jacksonville and Dean of the UF College of Medicine Jacksonville and Vice President of Health Affairs. And he is thought to be the first in Florida to be vaccinated with the COVID vaccine. I will let him speak to that, but I know there was an article about that. Also, UF Health Jacksonville was designated as one of the Pfizer 5, a handful of sites in Florida selected to receive the initial distribution of the COVID vaccines. Dr. Haley grew up in Pittsburgh, and he dreamt of becoming the first African-American sportscaster, but that changed when he had an injury, and that's what led him into his fascination with medicine. As a student at Pittsburgh Med, he completed a summer program working shifts at the emergency department at St. Margaret's Hospital. The variety of injury and trauma cases that came through for him inspired him to pursue emergency medicine. Then he completed his residency at Henry Ford in Detroit, Michigan, followed by a master's in health services administration from the University of Michigan. From there, he moved to Atlanta, where he became professor of emergency medicine at Emory, as well as the university's executive associate dean for clinical affairs for Grady Memorial Hospital. Then during his tenure there, he implemented a rapid medical evaluation process that shortened emergency medicine patient waiting times by 45 minutes and reduced the length of stay for patients with the least pressing cases by 3 hours. The process also drastically decreased the number of patients who left without receiving care by 50%. And Dr. Haley, as I stated, he was named the Dean of the College of Medicine and Professor of Emergency Medicine and Vice President for Health Affairs at the University of Florida, Jacksonville. He is focused on teaching clinicians on how to function in the digital environment. He thinks that is critical, and he emphasizes analytics, economics, and a push toward preventive medicine. He has authored multiple publications in the medical field as well. So we're very honored to have you here. So without further ado, Dr. Haley.
Great. So I guess I'll just present or say a few things, and then happy to answer any questions. So I appreciate the introduction. Boy, that must have been an old one. You found some stuff I'd forgotten about, but that's okay. It's all good. So so I am the CEO at UF Health in Jacksonville, and like everybody else on the phone, we've been dealing with COVID for a significant amount of time. We actually opened up our command center back on March 2nd of last year. And we are rapidly approaching, almost 1 year of managing COVID in one capacity or another. Early on for us, for our experience, it was really around probably like, and I apologize for being late to the call, was really more around acquiring PPE and understanding the disease, less so than actually taking care of a lot of patients. I think, as most of you know, the state sort of avoided that initial wave. In fact, probably we thought we had gotten through it until the summertime hit. And then we obviously had a very significant rise in the number of our hospitalizations as a hospital, as well as the city, as well as the state. One of the things that we tried to focus on, though, in that early phase was our community. So probably like many cities across the country, there was the rapid concept of the drive-through testing, which obviously is very successful and help protect people and help us get the sort of the contract tracing pieces under equation. But as a safety net institution with a very large community focus, we also wanted to do something a little bit different. Many of our patients don't have access to a car or to a vehicle. So we really just went straight into their neighborhoods and tried to do some testing right at some of our community centers, and partnered with actually our colleagues in Gainesville, partnered with the state, and we're able to really bring community COVID testing right into the community, right into the senior centers. We ultimately partnered with the homeless shelters. And so a big piece of our focus was making sure that we could test people who couldn't access testing in the conventional fashions. Much like everybody else went through the usual downturn in the fall, and but knowing that there was going to be a second rise, and certainly like most everybody else, we are certainly deep into that second rise. We've actually passed where we were over this past summer. In terms of the number of volume in cases, the acuity level is still high. And we've been actively engaged like everybody else with treatment protocols and parameters, working with monoclonal antibodies. We've set up an outpatient center to make sure we can deliver that care. And probably like everybody else, we've really been stretching our staff and our resources. So we're taking care of patients in places that, quite frankly, we haven't used in 15, 20 years. Our simulation center, for example, on our campus is the old emergency department at one of our old hospitals. We actually reconverted that back into a treatment area, and so we've been taking care of patients there. We bought out our hospice unit from the hospice vendor, and we're going to use that for the next 3 months. And have really been trying to manage, this sort of significant rise in COVID patients while still delivering, our elective surgeries, elective procedures, taking care of patients with heart attacks and strokes. And that's been, a significant challenge for us as an organization. As was mentioned earlier, we were chosen as one of the Pfizer 5, so 5 hospitals across the state that were sort of that original cohort to receive the Pfizer vaccine, in part because, one, our location being the supplier for Jacksonville, but obviously having the freezer to take care of the vaccine. We were originally provided with a little short of 20,000 doses of the vaccine, and the request at that point in time was to vaccinate our staff and share with the other hospitals in the region, which included, in our mind, Gainesville. And so that's what we did. And I was not planning to be the first person to receive the vaccine. We certainly have a lot of other frontline healthcare workers that I thought were certainly more deserving. But I will tell you, I had a lot of staff who were very apprehensive about taking the vaccine. They asked, was I going to take it? Was I going to be first? After some conversations with leadership, I made that decision to actually be the first. I didn't know I was going to be the first in the state, but that just happened to be a timing question. So first in our setting, in part because the staff were uncomfortable and I wanted to give them comfort, but also particularly as an African American in our community, where, as we all know, COVID has been absolutely devastating in the African American and Hispanic community, 2 times the hospitalization, 2 times the cases, 2 to 3 times the deaths. I felt was important, and distrust in vaccines and research, and I felt it was important to show leadership from the perspective of an African-American physician leader who believes in the science, feel comfortable with the vaccine, did it publicly. Didn't do my second one publicly, but it went fine as well. And I will tell you, I think it has helped us get more of our staff, because when we originally did our survey, we only had about 30% of our staff members who felt like they were going to take the vaccine. And I think we're right around 60% now. And so that's been very helpful. So we received the first dose, and that was on December 14th. We received dose set 2 on December 31st. And unfortunately, that's all we've been given. We have not been provided any Moderna. We have not provided any additional Pfizer. We have taken it out to the community again and are vaccinating seniors until we run out. So we've been vaccinating seniors of our staff, seniors in our community, in some of our underserved communities. We did a group of pastors here, again, to show leadership in the African-American community, and hopefully encourage trust in the vaccine and in the process. And here we are now, at the end of January, and we're about to completely run out of dose 1. We obviously are still vaccinating dose 2. And then hopefully we can work with the state on sort of their next delivery cycle, although I believe that they've kind of pivoted away from hospitals and want to use the Department of Health to support that. So that brings us up to where we are right now. Hope that sort of gives you a quick overview of kind of how we've approached it in our organization, and happy to answer any questions. You're on mute.
Thank you, Dr. Haley. So we do have a question. So is there anything that you think could have been done differently during the initial rollout phase of the vaccine to get it to more people sooner?
I think using the 5 hospitals as an initial approach would have been good. I think the one thing what we may have done differently is, and I understand now the state's perspective, which was, let's make sure we start to share it with other institutions. And at first, when share meant actually we had to literally send a staff member over to the other hospitals and have them essentially watch the process and then take all the information back. And then finally, we got the state to agree to let us transfer it to other institutions. So I think, because they were so worried about vaccine supply, that they put a couple of rules in place that slowed the process down. Probably in hindsight, I think the hospital approach was reasonable, but I probably would have had the hospitals try and figure out exactly how to get not only their own staff, but the other hospital staff as well. We've got a very efficient process on our campus. We can do well over 1,000 people on our downtown campus during the course of we can pull that off in about 7 hours. Obviously, we could have run that longer. We could do it differently. So I think probably trying to concentrate it to a single health system and let them sort of be solely responsible for helping to get that out, I think would have been the first part. I think the second part was it was never clear how they were going to distribute to the cities so that the cities could take care of first responders and seniors. So if there had been more clear process that, the hospitals were going to get X doses, the cities were going to get Y, then I think people would have had more systematic approaches to it. Because unfortunately, what you saw is, people waiting in line, using different forms to schedule an appointment, phone calls, phone lines that blew up. And part of the reason why is, you never knew how many doses you had. So for at least the city of Jacksonville, they almost had to wait till they knew what they were going to get. Then they would try and set something up. So I think doing that would have been a little better. Now, that being said, the state of Florida is, I think, 1.2 million vaccines that have been given. I think Texas, I heard this morning from Dr. Rifkes, I think Texas is around 1.4, California is around 1.5. So we're third right now. We could certainly have done more. I think the biggest challenge right now is just understanding the supply chain. So like I said, we've essentially, if you think about it, been given one round of vaccine. Obviously we begin both doses, but that's it. And we hear that the state is going to pivot, but we haven't been told that differently. I think most of the big health systems, I'm looking at some of them on the screen, we can do thousands of people a day if necessary, but without knowing the supply has been very, very difficult.
And how do you think we can improve the vaccine distribution process moving forward?
Well, one, again, getting back to understanding what we're going to get, right? So it is, have to know at this point in time, we literally, if the state were to call me today and say, we got more vaccine for you, I don't know what that number is going to be. So I don't know, it's hard for me to set up appointments, right, to get people scheduled if I don't know what I'm going to get. So I think the biggest issue is sort of the supply chain piece of that, so that, if hospitals are going to be involved, great. If the city is going to be involved, great. But right now there are so many unknowns about what you're going to get. It's hard to get people scheduled. If you think about it, we could schedule people for the next several months if we knew what we were going to get, right? If you knew what you were going to receive, but right now we don't. And it isn't clear where that piece of information breaks down. Is that at a federal level? Is that at the manufacturer level? Is that at a state level? So there's so many unknowns that it's been very difficult to predict. So I think the biggest thing is just getting more vaccine in the hands that people can deliver. So that's the hospitals, that's the state. We can do that efficiently, but if you don't have the vaccine, it's very hard to schedule and get people set up and ready to go.
Thank you for that. And I guess, Dr. Lenchus, do you have anything to say as well as to how we can improve the vaccine distribution process moving forward from your experiences at Broward Health?
Yeah, I agree with Dean Haley 100%. It's impossible to figure out how many people you're going to vaccinate without having a supply. I do think that perhaps instead of targeting these 5 areas, I know why those 5 hospitals were selected, but I think instead of doing that, maybe the county governments should have activated their emergency operations center and drawn their resources in to set up different places around the county where that could be staffed by county employees, as opposed to tapping the already severely shorted staff that we have in the hospitals to take care of patients. So when the state dumped it on the individual hospitals, we all did our own kind of hodgepodge in setting up programs like Dr. Haley mentioned, and we've become very adept and very quick at being creative and being able to pivot in order to make these things work in order to vaccinate as many people as possible. But there's staffing components that have to go into that. There's equipment that goes into that. There's facilities, place, electricity, food, observation. There's all kinds of logistics that go into standing up a center like that, especially outside of the hospital, let alone earmarking a center inside your hospital in order to account for vaccinating your own employees. And all this is under that black cloud of not even knowing how many of these things you're going to have. So fortunately, I think the demand is exceedingly high. Unfortunately, that demand is so high that it eclipses our present supply. And I'm optimistic that the manufacturers will continue to pump out these vaccines and get them to the places that can actually administer them over time. But I tell people, look, to be perfectly honest with you, you waited 10 months to get to this point. I apologize, you're gonna have to wait a few more weeks in order for us to get you the vaccine. That's not a hospital thing. It really is just a supply chain thing.
The other thing I would say, and this is not Florida unique, unfortunately, we also have probably 50 different state approaches to vaccine delivery as well. So, state of Florida took the hospital approach first and then pivoted from hospital workers to those over 65. Other states, like my parents live in Pennsylvania. Pennsylvania has been very strict about staying with group 1A, right, from the CDC recommendation. And they just got to seniors. My parents are 80 plus years old. So they just got their first dose of vaccine on Saturday. So, every state had these very different approaches. Every state, a good friend of mine is the CEO of the University of Maryland, the University of Maryland Health System. And this entire state of Maryland only gets 17,000 doses of vaccine every week. So, and it's unpredictable who gets what. So it's impossible to get people out. So there is a component to all of this on the actual supply of the vaccine, right? And whether that's the true manufacturing of the vaccine or if it's manufacturing and sitting in their warehouses getting there. So there's a great question around the variants. And so right now, what we understand is that both vaccines, the Pfizer and Moderna, should work for at least the British variety and the South American variety. There is some concern that the Brazilian variety is a little bit different. I believe it was just announced today that Moderna is going to work on altering their vaccine to meet the needs of the variants, and it may require a booster later on. I have not heard anything from Pfizer, but I do think probably the most important thing about the variants is it's a reminder that at least for some time, we are still going to have to wear our masks and be socially distant and, wash our hands because, I'm guessing many of the people on this call have been vaccinated, but not necessarily all. And until we really get a hold on all the variants, we're going to struggle a little bit. So even for those of us who've been vaccinated, there's some literature that would suggest that you are still carriers. There's all the literature that says we're not. But clearly, I think the most important thing about the new variants is, we still are going to need to mask and distance and wash our hands, probably till the summer.
And now another question, Dr. Haley, as far as the administration of the vaccine or treatment in your area and UF, have you noted any disparities that you think are in line with what we've seen out there with certain research studies that show that there are definitely disparities between certain populations? Or would you say that that's not valid based on your experience?
Well, we are definitely seeing disparities from the perspective of who has COVID, right? So if you look at our patient population, if you look at the city of Jacksonville is about 30% African-American, smaller Hispanic percentage, and the majority is white. If you look at our hospitalization numbers, it's about 60% are African-American, 30% are white, and the remainder Hispanic, Asian. So it's almost a complete reversal of the population in the city. So the people that are getting COVID, definitely you're seeing. And that's a function, as we all know, of comorbidities. So, when we look at our database, people with obesity, diabetes, hypertension, high cholesterol, those are our biggest risk groups. And unfortunately, there's bigger numbers in the African-American population in the city of Jacksonville, which is helping to drive that. Then you throw in things around access and testing. And so, we went out in the community to test earlier, but we could only sustain that for a little while. So I believe the number of people that are being tested in some of our underserved communities less. So unfortunately, the potential for spread is higher. Once they get to us, we feel fairly confident in, making sure that our treatment is standardized. In fact, it's order set driven in our computers. So it takes away some of that decision making, and we follow a certain protocol. So I think we've done a reasonably good job once they get here. Now, if you look at our deaths are still tilted towards African Americans, in part because the number is. The only other one that I haven't seen any data on, our data yet, is on the outpatient monoclonal antibody therapy. Truthfully, I don't know what our numbers are. We've done a small number. Quite frankly, it hasn't been quite as popular as we would want it to be. So I'd have to go back and look at that number. So yes, there's definitely disparities, you know, who gets it, who's coming to the hospital with it, where the discrepancy are. Once they get here, we feel comfortable with how we're treating them, although I still need to look up the monoclonal group.
Thank you, Dr. Haley. I don't know if maybe Dr. Champion would like to add something about the monoclonal, the research that you had done to add to what Dr. Haley said.
Yeah, I mean, the monoclonal antibody that I did research on is not connected to the outpatient program that we have here, but it is an exciting opportunity for our population, just hoping that we can get the word out more.
Thank you. And also, there was a question for Dr. Lenchus, which I just wanted to clarify. It states whether Dr. Lenchus was denying the existence of racial disparities, but I believe he was stating that he was referring to data that wasn't specifically accurate in certain situations. So if Dr. Lenchus, you could just clarify that so that your comments don't get misinterpreted.
No, I think that there are racial disparities. I agree with Dr. Haley. When people are in the hospital, I haven't seen the disparate patient population that he has, although the makeup of the population in the city of downtown Fort Lauderdale is very different than the city of downtown Jacksonville, as it would be in the city of Miami, where there's probably a predominance of Hispanics more so than, say, in Gainesville. So no, there have been undoubtedly racial disparities. I see them when they come to the hospital. We have all kinds of people that are in the hospital, and I do not see a disparate number of people dying of one patient population versus the other. I do see, like I said earlier, I do see that a large percentage of the people that are getting a COVID vaccine are not minorities, but that's not because it's not offered to them. It's because of a host of other reasons that I alluded to earlier.
Thank you. And now if anybody would like to ask any questions, you can turn on your video chat, or you can put it in the chat. So this will be the last call for questions for either Dr. Champion, Dr. Haley, or Dr. Lenchus. So feel free to raise your hand or put a question in the chat, and we will address those questions.
I just wanted to clarify something that we spoke about earlier in the call that Dr. Lenchus spoke about. As far as the data for my specific medication, the data shows those who participated. What it doesn't show is those that declined to participate, which was overwhelmingly a majority of African-American populations. We had to go to literally all over the country for months and months and months to get the results that we got. So we worked very hard to make this drug as generalizable as possible to the populations.
Thank you for that. All right, so anybody else have any questions? All right, I guess we don't have any other questions right now. Is there anything else any of the speakers would like to add to conclude our today's Fireside
Maria, I'm
chat?
sorry, I had one question.
Okay.
I just posted it there. So my question was, does the location of the patient impact their ability to obtain the vaccine, whether you're in a rural town, or rather a rural area, a small town, or a large city somewhere? I know that a lot of hospitals throughout the country are closing their doors, unfortunately, or they're just bursting at the seams. You know, and I'm assuming that this is where most people are going to get the vaccine shots. Is that playing a role at all in the disparity for people and their ability to get the vaccine?
No question. Yeah, because you have limited supply. Because right now, if you think about the way the states approached it, it's hospitals first, so the Pfizer 5, and then became the Moderna group, which is about 173 hospitals, and then a little bit left over that they've been providing to the cities. So depending upon your accessibility to any one of those has probably limited or allowed you to have easy access to the vaccine. So yeah, there's no question in my mind that, you know, if you're in a rural environment and the next hospital is not for several towns over or several counties over, probably very limited in your ability to get there. And how the state and the state's been using the public health service as well. So it's just been limited. So I would imagine, yes, depending upon your relationship or your distance to a major health system, to another hospital, to the state, would definitely impact your ability to get the vaccine. And almost all of the centers right now are still driven up from a model of you have to go get it, right? So whether it's to a hospital or to a, you know, in the case of Jacksonville, they've been doing it as a convenient, at one of the malls. So for people who can't travel or get in a car, now we did work on a small project with the Transportation Authority where they would go pick up patients. But if you don't have access to a car, then it also is probably eliminating your ability to access the vaccine. So yeah, that adds to, I think, one of those earlier questions about Rob, the vaccination distribution has been, you know, uneven.
The only thing that I would add to that is inherent in the vaccine. So the Pfizer vaccine requires a subarctic freezer storage system that even within the state of Florida in large areas, there was no ability for them to acquire that refrigeration that was needed. So I can imagine that if that was difficult in larger areas, forget about it in terms of a rural area trying to get a freezer of that caliber. Without that freezer, you can't have the Pfizer vaccine. So, so that would relegate them to a little bit of a delay in terms of waiting for the Moderna vaccine, or next up is probably the Johnson & Johnson, which requires just simple refrigeration and freezer storage. So that certainly would play into that as well.
Thank you. And then we have one last question. Are health facilities engaging with private partners to aid in the vaccination effort? And if so, which are the partners?
For us, we partner with the Jacksonville Transit Authority to help get patients to the hospital so they can get their vaccine. We've partnered with the Duval County Medical Society to help with the healthcare workers who are not associated with a facility. So you can imagine sort of the dentists, chiropractors, other groups. And so we've partnered with them. We probably could do more if we were going to get more vaccine, but sort of in that short limitation, that's primarily who we've partnered with.
Thank you. All right, well, that concludes our Fireside presentation for today. Unfortunately, we are out of time. So thank you very much for everybody's input. It was certainly valuable to me. I hope everybody resonates the same feeling. And thank you, Dr. Champion, Dr. Lenchus, and Dr. Haley. Florida Bar Health Law Section is honored to have had you here today.
Thank you. Thanks for having me.
Thank you.
Thank you.